is my disclosure slide. My talk is metabolic syndrome and diabetes and testosterone and how they're related, and hopefully give you a flavor of the implications and long-term complications of this. So this is actually modified from an accredited program for primary care physicians. This is a grant from Solvay Pharma, and I've sort of truncated a little bit and had the pleasure of getting involved with the program myself. So we know that obesity is a big issue, and that as we get more and more overweight, there's manifestations of that. And the metabolic syndrome is fat that is, of course, not all over. It is central body fat. It's the fat that is inside the body. And you can see, this is a little pointer here, the in red, my little laser pointer, there it is there. You can see in red here as it's increasing, and the Maritimes and the Northern Territories, I guess they need is insulation, the colder areas in Saskatchewan. And it's going up progressively, and with that comes along the complications of it. More diabetes, it's somewhat of an epidemic. Huge financial impact of this increase. And you can see the years 2000, 2010, and 2016. This is age. So comparing a average 60-year-old in the year 2000 to 2010 and 2016 in terms of incidence of diabetes, it's going up quite markedly. Earlier, one of the speakers said that all patients with diabetes should see an endocrinologist once in their life. It's not possible just because of the numbers. In the United States, they crunched the numbers a few years ago. And if every endocrinologist in the United States did nothing, no thyroids during this pituitary, nothing but diabetes, and worked full-time, it still ain't doable. So primary care, is where most diabetes does occur and should occur. and with ones that are maybe more of a problem can be referred to specialists. So the metabolic syndrome, this is Canadian data again, and again with in parallel with the obesity issues of the Maritimes and whatnot. So you're not talking just abdominal circumference per se, but it's abdominal circumference with central body fat. If the fat is in pinchable areas, that's not as metabolically mischievous, or not metabolically mischievous, whereas the fat that is in the mesentery, perinephric, around the liver, and whatnot, that stuff has insulin resistance as is associated, increased risk of diabetes, hypertension, sudden death, dyslipidemia, and hypogonadism. Not good stuff. Metabolic syndrome criteria has been modified a little bit. This now can be actually sub-modified into different ethnicities, which I find logical but completely confusing because it has too many numbers to try and remember. But generally, there's 5 different fields. There's how much of central body fat you have. It's a gender difference here. 40 inches or 35 inches, 100 or 102 or 88 is the cutoff. Whether the triglycerides are up, whether the HDL is low. And the cutoff here is actually, I was amazed how good it is. I mean, if you had an HDL of 0.95, as a guy who usually think you're doing kind of well, actually, from the national average. Blood pressure over 130 over 85, and a fasting glucose of 5.7 or above. If you have 3 of those criteria, you have the metabolic syndrome. Why do we care about metabolic syndrome? We care because of the complications that travel with it. These patients have twice the risk of cardiovascular, fivefold, so twice the risk of cardiovascular events and a 5-fold increase of getting type 2 diabetes, with then the microvascular complications that come along with diabetes. So here's a patient, bringing this back to reality, a 53-year-old gentleman with long-standing well-controlled type 2 diabetes. He comes in and he's had erectile dysfunction. He, for 2 years, his BMI is 29, his blood pressure is 140 over 90. He's on metformin, a statin, an ACE inhibitor, and aspirin, the usual collection of medications common in this group of patients. So, is this a common thing? Testosterone, erectile dysfunction, diabetes? Yeah, absolutely it is. And the ball got rolling on this in a study that was done in 2004, I believe now, at JCM in Buffalo. And they just did a cross-sectional study of their patients with diabetes, 103 men aged 28 to 80, so a bit of an older cohort, but all type 2 diabetes and some young patients as well. And they measured both a free T, a calculated T, or a total T. And they found 2 take-home points from this. The first thing is that total T doesn't do well. It actually overdiagnoses those that are actually deficient. Because of the drop in sex hormone binding globulin that occurs with obesity, type 2 diabetes, you get a falsely low total testosterone, but the bioavailable or the free is actually still normal, and the guys actually are not hypogonadal. But if you used a free T, a true free T, it's about 33% actually, which were hypogonadal, and that's, you can see the different breakdowns, and that's more than you would expect in the general population. And a bit of a surprise actually when that came out, that it was to that degree. This has since been shown in a number of other studies, that somewhere around 30, 35, maybe even 40% of men with type 2 diabetes have hypogonadism, generally hypogonadotropic hypogonadism, a suppression of pituitary function. And it's sometimes symptomatic. This actually breaks it down, because some of those guys don't actually feel it. It may have metabolic repercussions, but they're actually not feeling symptoms. But if you look at symptoms, you can see similar curves, and again, increasing with age, libido, ED, fatigability, decreased muscle strength, and mood. Those are important symptoms. You know, one of the things we try and do with this patient population is get them to exercise, have them lose weight if they can. But if they're hypogonadal, one of the symptoms of androgen deficiency is you're tired, you don't feel like exercising, and when you do exercise, you have post-exercise fatigue. So potentially, treating these gentlemen may actually be advantageous. Now, those are cross-sectional studies, and they don't actually give you a cause or effect. And since there are a number of studies looking at which was first, what's the chicken or the egg? This is from the Yale, Massachusetts aging study. And in this study, having a low free testosterone or a SHBG level, it was predictive going forward over the 8 or 9 years of the study of risk of developing diabetes. So it suggests that in these men, it can be causative. And we know that if you render men hypogonadal, you increase their insulin resistance, they tend to get visceral body fat increases, and they tend to gain weight. So you've got a biological mechanism for it, and you've got studies suggesting it occurs. Here's a study. This is from Fred Wu. I stole slides from him. This is the European Male Aging Study, and it correlates various degrees of androgen state with insulin resistance by HOMA, with glucose levels, with insulin levels, and with the presence of diabetes. And you can see as you go from eugonadal to mildly deficient to markedly deficient, you become more insulin resistant. You become tend to have higher sugars, increased insulin levels as your body tries to compensate, and you tend to develop more diabetes. And you can look in that patient population and see the same thing exactly with the metabolic syndrome, that it increases with an increase of fat and low testosterone level. This is the first study that I recall that suggested you could change body composition with testosterone. This was with Per Marin with T-undecanoate oral in hypogonadal men. And I like this study still to this date, although it's getting a little dated now. This is 1992. It's 20 years ago. Back then, there were not a lot of these studies. Anyway, I like this study because he took these hypogonadal guys and showed that they would lose weight on testosterone. They would tend to have an increased risk or trend increase in body mass, and they had a decrease in body fat. And he broke it down with total body fat and also visceral fat, the bad fat. And both those compartments had a statistically significant reduction with the active treatment group. So take that data and put it in a diabetes population who have insulin resistance and central body fat. And this is a core study, I believe. You can see over there on the side. Published 7 years ago now. And this is a study looking at hypogonadal men with type 2 diabetes. It was a small study, but nonetheless, 24 men with randomized crossover study of treatment with testosterone with a washout or not. And you can see this is baseline placebo, and these guys became more insulin resistant with time, whereas those on testosterone, a significant reduction in insulin resistance. And in terms of hemoglobin A1C, which has been our marker for complications of diabetes, there was a significant reduction in hemoglobin A1C in men who got the testosterone. And that correlated with change in waist circumference. So these gentlemen were losing central body fat on testosterone, as we can see in the Marin study back in 1992. So that's a small study. Nice to see A1Cs improve. The man felt better because they were hypogonadal. It's not a long-term outcome study. It doesn't tell us about diabetic complications of either micro or macrovascular disease, but it's sure food for thought. And clinically, with this kind of data, I mean, where I use this particularly is in terms of screening men, those men that just can't get exercising and can't maintain. If you find that they're hypogonadal, you may actually give them a real leg up in starting to exercise and improving their metabolic status. This is a meta-analysis now of a number of other studies, including the Kapoor study we just saw at the top there, that have been done looking at the same population in men with either type 2 diabetes or the metabolic syndrome who were treated with testosterone. It's not universal that they get an improvement in hemoglobin A1C, but in general, they get an improvement in insulin resistance. The most recent one was the Jones study, which was done in the UK. They actually had a p-value at 6 months. They lost their p-value for A1C drop at 12 months. But it's provocative. What do we do with this data? We keep getting more of it. It's not an outcome data. It's provocative. I don't think giving men, or should we phrase that, giving men who are not symptomatic but have type 2 diabetes with hypogonadism, I don't think we should give those men testosterone in today's world because we don't have outcome studies. But if they are symptomatic, it's fair game to treat them, and hopefully they will be individuals who will respond. Anecdotally, and this is just me talking, I think somebody's got to do a study looking at duration of diabetes and how they respond. As men get older, they become more insulin deficient. And Grady Manili in town has done some of this work, whereas an older man with type 2 diabetes is more likely to be insulin deficient than insulin resistant. And the converse from a guy who's like 45 and has a big tummy, his major issue may be more insulin resistance, and he still has retained good beta cell function. My gut feeling is you put the 45-year-old on testosterone, that's the guy that's going to lose fat and have a drop in his hemoglobin A1C, but the 75-year-old, not so much. And that individual's unfortunately lost too much beta cell function, which is the nature of the beast and why he got diabetes in the first place. But that hasn't been done in a study, and somebody hopefully will do that. This is looking at our patient population of men who have unfortunately been rendered hypogonadal in prostate cancer, and in this sort of unnatural experiment, I guess you might say, you can see that they increase their body fat mass, and they also get an increase in insulin levels and a trend upwards, elevation of blood sugar as well. So it's a very common entity, hypogonadism in both obesity, type 2 diabetes, and metabolic syndrome. The HIM study suggested actually a sort of amazingly high, it's like 38% as I recall in the HIM study, incidence in men over the age of 45, and 2.4 roughly odds ratio in obesity, 2.09 in diabetes. And they didn't look for metabolic syndrome per se, but that's probably tucked in here, and hypertension at 1.84. But all the things that were associated, it's the overweight individuals with systemic disease that have the highest incidence. This is again looking at metabolic syndrome per se, and looking at it's about 2.5 increase. So getting back to our patient. 53-year-old man with long-standing, well-controlled type 2 diabetes with erectile dysfunction. What do you do with him? Measures testosterone level. The answer in today's world is yes, that's the guidelines. He's got erectile dysfunction as well, and you find his total testosterone level is 9. That by itself really doesn't tell you much, because again, many of these individuals have low sex hormone binding globulin, and so they can have total testosterone sometimes of 8, 9, maybe even 7 sometimes, and still actually have normal bioavailable testosterone. In this case, the bioavailable testosterone came back 2.1 with the cutoff of the local assay being 5, which fits in with him. He has symptoms, he has erectile dysfunction. Screening for gonadotropins is usually non-productive, but we do it to make sure the prolactin's normal, check his PSA, thyroid function, make sure he's not polycythemic. And by the way, we didn't talk about that this morning, but I find it really, really helpful. Getting a CBC. Most men who are androgen deficient are mildly anemic. It's the nature of the beast. Beware of the man whose CBC is normal and the individual whose hematocrit or hemoglobin is high normal. I send some of those guys to the sleep apnea clinic even in the absence of symptoms, because that's the reason they got the high hemoglobin level. So what are the guidelines? The 2008 Canadian Diabetes Association guidelines are to measure testosterone in men with type 2 diabetes who do not respond to PDE5 inhibitors, because we can hopefully salvage them by rendering them eugonadal and then re-challenging them with PDE5 inhibitors. And with the Endocrine Society guidelines, some form of screening our men with type 2 diabetes. Again, I don't do it every year, but I like to know what their status is every 2 or 3 years, or if they lose a lot or gain weight. So in summary, decision to use testosterone is based on a clinical pattern with biochemodynamics of testosterone deficiency. We heard about the mood changes, body composition, bone mineral density changes, the importance of being eugonadal if you're trying to maintain erectile function, and these tantalizing effects in our insulin-resistant population, which I don't think right now is ready for prime time until someone has an outcome. But if you have a patient who's symptomatic of hypogonadism and who has the metabolic syndrome or has type 2 diabetes, you may well get a beneficial effect with treating them. One more slide, not the question. This is my modified Wheel of Misfortune, with apologies to the original author. It doesn't project as well on my screen. But the metabolic syndrome of insulin, a new paradigm. We know that when you get insulin resistant, depending on your, your metabolism, you may get hypertension, you may get dyslipidemia, you may get high sugars. If you're female, you may get polycystic ovarian syndrome, you may get gout, you may have premature coronary disease. And all these things are related. Sometimes we see the cutaneous manifestation of acanthosis nigricans. But now there's sufficient evidence that getting insulin resistance also causes hypogonadism in men. And I think we should consider it part of the insulin resistance syndrome. And I'll stop there and take some questions. Yes, Chris Bebb.
Sorry, two. First one is for polycythemia. So the realistic part of that clinically is that it's going to be like the most common virus of FBC. And I don't know what the resources are like in BC. So how do you monitor them? And what happens if they actually are creeping up polycythemia? What are you doing adjustment-wise on testosterone? And how are you dealing with the actual polycythemia?
Okay, was there a second question?
The second one's going to be going to throw a little curve on that diabetic.
Okay, so the first question was, what about polycythemia and how do you deal with it here in BC? It's expected that hemoglobin levels are going to go up. Remember that the male and female normal ranges are different. So it's expected that you're going to see in someone who's profoundly hypogonadal an increase of 10, 15, even 20 points. And that's normal. You're restoring normal physiology. If you have a man who has sleep apnea, they quite often can get pushed into the excessively high range. By excessively high, in my mind, I use a cutoff of a hematocrit of 52%. I believe at 52% or low that it's a very safe situation to be in physiologically. At sea level, 1% of us can run a hematocrit over 50% normal, okay? So that can be normal. There's case reports of thrombotic events occurring when you get up around 56%. Despite what was on one of the earlier slides about testosterone causing thrombosis, I've looked at this extensively, and I personally do not believe there's literature that supports testosterone being prothrombotic in the absence of polycythemia. So if you haven't caused polycythemia, I don't believe it is prothrombotic. Quick little scenario there. I saw a patient I'd seen 10 years ago and put on testosterone who went in with a swelling of his left upper extremity, and he had a DVT in his left shoulder, and Lionsgate, and they stopped his testosterone. The testosterone caused the blood clot. And then the evidence is not there that it does it. So he comes back into the Men's Health Initiative feeling horrid because his testosterone level is like 1.5. and I said, this doesn't make any sense. I mean, IV drug users pass out on their arms, they get DVTs. Guys who hurt themselves at work, traumatic upper limb DVT, sure, that can happen. So I actually sent him off for a CT and MRI and had a venogram. He's got a cervical rib up there with compression of the veins, which he had resected. He's back on testosterone. The testosterone was not the cause of his thrombosis, but it is out there that that's part of it. So I usually cut off 52. Some people use 53. It's a part of therapy. It goes up. It's worse with injectable. It is the peak that occurs 2 or 3 days after injectable testosterone. That's our enemy. If you take men who are hypogonadal, you give them 300 milligrams of testosterone every 3 weeks versus 100 every week. It's the same dose, but the incidence of polycythemia is huge in the 300 every 3 weeks, but very low. It's going to be maybe 10% high normal in 100 every week, but you're talking up to around 30% of guys will get polycythemic at 300 every 3 weeks. It's actually not that high in real life because guys are late on their shots and whatnot. The incidence with transdermal formulations is about 6%, and I've seen one patient on testosterone undecanoate oral have it. So sometimes if they get it, if they're on the shots, contract the dose interval, reduce the dose, make sure they're not hyperphysiological, consider switching to a different formulation. One has a lower inherent risk of causing polycythemia, and then make sure there's not secondary factors that you haven't missed: sleep apnea, smoking, occult lung disease, and try and keep them below 52%. That's the way.
What's your step in the clinic? So he's in there, he sits down in front of you, it's 54%. So where are you sending him to do what?
So he's 54%, and what's he taking?
He's on injectable, and let's say he's on, so we just talked about dose injections. So let's say he was on 300 every couple of 3 weeks.
So if he was on 300 every 3 weeks, and he has that, I'd ask him to, he's in the danger zone in my mind, I'd ask him to miss the shot for a while, 2-3 weeks. Remember, it takes 3 months for a cycle of red cells, and I want to know that he's dropping, and that I'd offer him any of those options. If he wants to go to weekly injections, that'd be great. We might be able to get away without a dose reduction by getting rid of his post-injection peaks, and then follow him along and see. Now, there are the occasional guys, most of them are smokers in BC, who have to be on injections because they can't afford anything else, and the government here in BC doesn't pay for it. And I do it as a last resort. Absolute last resort, and I think I can still count on one hand the number of guys I have that need phlebotomies. I hate doing it, personally. I'd rather try and give testosterone more physiologically, because this is my British belief that causing polycythemia is a side effect of the form of testosterone usually, or in those individuals, the case would be the people who can't tolerate the CPAP mask, have mild sleep apnea, or moderate, or hypogonadal, and I got to put them on testosterone anyways. A couple of those guys are on phlebotomies. It's a pain. Do you want to comment on your experience?
I think the rarity of needing a phlebotomy is exactly what you said, but I think that invariably with all the people in this room, this is going to happen in the next year, that they'll have a couple of patients because of the critical mass of the number of people. And it's always nice to have your plan ready.
Yeah.
And having your plan ready so you know you're setting them up for a phlebotomy if they're like 57, 50, 59, and you've got other risk factors. That makes it simple, as opposed to then you're reacting in that situation to something that you maybe weren't prepared for. So that was a great, I think, a great. But I really think it's the minority that have to go to phlebotomy. There's 99 times out of 100 there's a way around it. But there's going to be 5,000 guys that are treated with testosterone just based on this row here and the next one in front of them. So invariably, polycythemia is nothing to be fearful of. It's going to happen.
Yeah.
The likelihood of having to have a more direct treatment is very, very low. But we have an approach.
Yeah.
And that's
Perfect.
what I kind of make is that you can have a very simple approach that takes it out of this, oh my goodness, to a, and my this is what I'm doing.
Fantastic. It's a great question. Did you ever hear his answer just at the end there? That is going to happen very rarely, and just monitor. The key thing is to monitor the patients, follow the protocol. If they're going to get polycythemia, you're talking generally in the first 3 to 6 months, it's going to come up. If they have not developed it and you're monitoring them, they can be monitored every year with the usual follow-up. and they're not going to suddenly develop polycythemia out of the blue, at least not on the basis of testosterone. They can always get renal cancer and get a random producing tumor or something, but that's that. Why don't we just open it up for everybody, because we have like 5 more minutes. If any of the morning talks for the speakers that are still here, if you have it, so not just me, but yes?
Excuse my laryngitis, are most of your injections weekly then? You know, like almost all mine are every 2 weeks. And I would find it a real hassle to get my patients on injections every week for testosterone.
So the question is how often do you usually prescribe injections? The guidelines, the Canadian guidelines that came out, Stacy has sort of scooted it out, but the person who was writing the paper is a lovely man, and we kept trying to get that every 4 weeks thing removed from the guidelines because it's in the CPS, and it's unfortunately still in there. And I just never, ever use testosterone every 4 weeks. We're talking about every 4 weeks and how it's still in the guidelines, because it causes a huge amount of polycythemia, and I don't really think in most men that you can get injectable testosterone in the forms we have in Canada to last more than 3 weeks. They're low the 4th week. If we had T-undecanoate injectable here, Nebido is called in most countries, yeah, that can last 2 or 3 months, but not T-ananthate or Stiffionate. So I start off every 2 weeks. Standard dose to start with is 200 every 2 weeks, and go from there. It is my target with men, and I tell them this, is that you didn't feel crappy every 2 weeks before your testosterone level was low. So why are we going to accept that right now? And if they come back in for a follow-up visit, and I ask them, can you tell when your shots do by how you feel? And they say, yes, that's the wrong answer. I don't think we should leave them like that. So I will then tinker with the dose, and quite often we'll cut them to weekly injections. Concomitant with that, I encourage them to learn how to self-inject. Most of these guys just want to feel normal. This is not the muscle building, weightlifting nut group. They just want to feel normal, and getting taught how to inject, or if they're worried about it or worried their partner can do it, they can do it at home every week. I have guys who do it every 10 days. You program your this is hard to remember, they program their BlackBerry or their iPhone to beep and tell them to do it. So whatever works, so that they feel normal and have as close to physiological lab results as I can get them 24/7 all through the month. So probably in the clinic, I don't know, it's probably maybe 1/3 of them are going to be on weekly injections. Is that fair to say? I think it's quite common.
If they accept it, that's the thing, is that they really need to learn to self-inject. It's too much to go to the doctor all the time.
It's a lot.
But it's a smaller dose too, it's a smaller volume of injecting, so it is easier.
The other thing is, that 200 every 2 weeks, if you start measuring the levels, it's quite variable. I've got patients that take 25 milligrams every 3 weeks. Their levels are physiological, it's still there. And conversely, we've been doing this for a while, I have a number of men who take 400, 450 a week, and you measure them on the 7th day before their shot, it's gone. It's incredible. Where did it go? They just metabolized it away, and that's it's surprising, but the more you practice, you'll see that. So you got to titrate the dose to the patient. Yes?
I've had a few folks who are sort of that granola bar crowd who come in with some bioidentical paste that they got from the pharmacy, and they use that instead of the prepared stuff. Could you comment on that?
So to compounded test, there's 2 parts of that. There's the bioidentical part and the compounded thing. To say bioidentical to an endocrinologist gives us reflux, and I start to tremble. And bioidentical is a marketing term. It's just a testosterone. And it comes from Suzanne Summers, who's is that recording? Okay, be careful. I'm not going to say anything. But she has some unusual views about causation of cancer and a few other things. Suffice to say, it is true we like to reproduce physiology and use hormone preparations that are close to natural as possible, to ascribe to them some magical quality because they're bioidentical is, I think, a marketing thing and not a reality. It is usually transdermal preparations that are compounded. I think they're valid. I don't tend to use them off the bat. There are patients that testosterone will not go across their skin. You'll do double doses of any of the preparation, Testosterone gets a bit better absorbed than Andriol, and you measure the blood level afterwards, it doesn't change. It's incredible. Whereas other men, they get absorbed well. So then they have permeation enhancers to get them absorbed. Now that said, I do have some men who were started on compounded forms. It gets absorbed. It seems to be consistent with their blood levels from batch to batch, and they feel fine, and they're saving money on it. That ain't broke, I don't change it. I have one little sort of caveat with that. Some of these natural therapies are putting in aromatase inhibitors in the transdermal preparation, which I think is wacko. Personally, I don't think there's any science to it, and I'm very concerned that in fact it's actually dangerous. As John Wade was just showing you about the osteoporosis issue, bone density in older gentlemen correlates more with free estradiol levels than free testosterone levels. And why you'd want to try and antagonize the estrogen is beyond me. And we now have a study out of Australia done by, the name will come to me, but what the study did was kind of cool. They were looking at actually a prostate volume in hypogonadal men. The premise of the study was that estrogen had a role with prostate enlargement as men aged. So if you took hypogonadal men and replace them with DHT, which cannot be converted to estrogen, you would then see smaller prostates 2 years later, which is indeed what they showed, okay? For what that's worth. Urology columns would talk about whether that's important or not. But in 2 years, depriving those guys of estrogen, they got spinal osteoporosis. So why people give aromatase inhibitors to hypogonadal men is making life really complex, potentially dangerous from the perspective of their bones, and not evidence-based. Don't do it.
And the weightlifters do that.
Weightlifters do it for another reason, to prevent breast development, because they're taking astronomically high doses. If you do that, you aromatize a lot of it, you cause breast development. So they're doing that for a reason. That's recreational drug use. We don't get involved in that.
But it might hurt the bones in the long run. Probably not long
Who
run.
knows?
There's enough resistance training going on.
Probably. What those guys get, if you have them in your practice, is they get absolute horrific joints. They blow their joints all out, and they have flail shoulders and stuff, and other things that develop arthritis.
So when we treat somebody to lower their cholesterol, does that change the biochemical pathway and decrease testosterone and estradiol production?
When you give testosterone, the question is, what does testosterone do to cholesterol? Okay. So, sorry.
As we lower the cholesterol, does it affect the sex hormones?
Oh, sorry, I misunderstood the question. The answer is no. So does using statins make men hypogonadal? Is the question?
Yeah.
The answer is no. With the power that we have right now, we can drop LDL about 70%. Right? If you look at big doses of Crestor with Ezetrol, that's about as good as we can do in today's world. So with that, if you look, and this is the early studies with ezetimibe when it first came to market, it does not change any steroid level in the body. And I think it might theoretically be possible one day, but you need an absolutely huge reduction in cholesterol. Keep in mind that LDL levels in 1 and 2 year olds is 1. They're growing quickly and they're just fine. Right? Get lots of cortisol. That's one line of reason. The other reason is the highest number of LDL receptors in the body is in the adrenal glands and the testicles and the ovaries. So anything, that's where it goes. So even at very low levels, those organs are really good at pulling out of the bloodstream, and they don't have. We've never been able to push human beings so low in cholesterol substrate that they can't make steroid hormones. That said, sometimes you talk to patients that go on statins and they say my libido's down. But they're not hypogonadal. It's some effect in the brain, right?
Yeah.
Any other questions?